All right, hi, I'm Dr. LaHood from Adelaide, Australia. I'm a cataract and refractive surgeon. I'm going to be talking about surgically induced astigmatism today. And you'll see from my front slides that I've got some different sports balls on there because when I'm describing astigmatism, I often tell people, look, sometimes it's your eyes shaped like a soccer ball, sometimes like a rugby ball. So I've got some different balls from different countries there just to represent that, just in case that wasn't clear. Now, my research interests, I've got a lot of varied interests, but they all surround about astigmatism. And so SIA is sort of the center of my Venn diagram. So it's a topic that's really dear to my heart. And if you're really interested, I do host a podcast, Ophthalmology Against the Rule, with my colleague Nick Andrew. And we did do a 3-part mini-series on SIA, which was a ratings disaster. But you may find it interesting if you want to learn more about SIA in more detail. So just the basics of astigmatism first. We've got light being focused in 2 different planes. It's not focused in a single point. And so most of that's from the cornea. We've got some lenticular astigmatism, and there's a little bit of astigmatism from the retinal shape, which no one really understands. So we'll just brush over that. Corneal astigmatism, really difficult to measure consistently, mainly because we've got a watery surface on the front of a moving sphere, basically. And so little changes in curvature are difficult to measure. It's constantly changing, and it's got a really similar refractive index to water of the aqueous, so difficult to measure between the posterior cornea and the aqueous. Really important to consider that low astigmatism is difficult to measure on any device just because it's such a low magnitude. And so when you're thinking about SIA, you're going to be measuring preoperatively and postoperatively corneal shape. And so you can get a small amount of SIA, not even from operating, but just from measuring the eye twice. Higher magnitudes of astigmatism are going to be easy to measure on any device whatsoever. The second concept that's important with astigmatism is to know that you should be measuring on the same device preoperatively and postoperatively, because different devices will measure your astigmatism differently at different diameters from the center of your cornea. The third point is that your cornea does have some higher order aberrations, so not just sphere and cylinder, but it has some other abnormal shapes that do act, I suppose they contribute to astigmatism in terms of your refractive astigmatism and can contribute to the measurement of astigmatism overall. So take that into consideration that all corneas are a little bit irregular. Now my favorite topic, posterior corneal astigmatism, just good to put in there because you've got to remember that the cornea is a window. It's got 2 surfaces, it's got a front surface and a back surface. They don't possibly align in most cases, and you've got to think there's a total corneal astigmatism that's a contribution of both surfaces. So we'll take that into consideration through this talk as well. So currently when we're calculating toric IOLs, we've got 3 different pieces. We're really good with axial length. Anterior keratometry is pretty good. We're not quite as good with effective lens position. We're okay with that, but not great. And we're really kind of bad at measuring the posterior cornea, measuring low magnitude corneal astigmatism, and measuring SIA that we'll talk about today. So why is it such a major concern? Well, it's the responsible part for why you might get a different result from what you planned. So you've got a completely different eye preoperatively that you planned the surgery, and postoperatively what you're dealing with afterwards. So 2 different eyes, and that's SIA, which is the difference. It's also kind of unpredictable, and it's relatively misunderstood. SIA terminology is important to think about. You might read some studies that talk about total eye SIA, and that's talking about the difference that you've achieved with the entire eye for your surgery. So you've taken a lens out, you've put a toric IOL in, that's the SIA for the total eye, but we're going to be talking about corneal SIA, which is the change in shape of the cornea only. All right, I think this is probably the most important part of the whole talk, some practical points about SIA. So if you look at this double angle vector diagram, this what would you call it? I guess like a dartboard. You've got different magnitudes of SIA. So each of those dots represents the change in shape for an individual eye. And you can see there that I've made the same incision over and over again. All of the black dots, they are one group of eyes, and all of the green dots are another group of eyes. So all of the black dots, you can see that the magnitude varies, the orientation varies, and overall you've got a mean SIA of the blue dot, which is quite small. But you can also see that the green dots, they all have a similar SIA, but because they're all distributed around the board, they give a very small SIA of the red dot. And so you can be fooled by just looking at the mean that won't take into consideration the orientation of the SIA. And we'll talk a little bit more about the different measures that there are. But overall, it's just important to know that you can get different average SIA from different ways. One way is having a routine, same magnitude, but at different orientations around the board, averages to 0. Or the other one is you truly have a small average. So the most common measure of SIA is mean magnitude SIA. And what I've done here is I've taken all of those vectors off the diagram. I think that the word vector can be a bit intimidating, but it just means the magnitude and direction of the change in shape of the cornea. Very simple term. And so imagine this is 4 different eyes plotted on the graph. So you've got 4 different blue arrows showing the magnitude and direction of the shape change. And you can see that they're all spread out because it is quite unpredictable, unlike we were taught. So for the mean, you ignore the direction, you take all of those arrows, you line them up beside each other, and you get an average. And that average is usually about 0.3 diopters, so relatively small, but not tiny, clinically significant. So, it's something that some people put into a calculator, and I think that's wrong, and we'll talk about why that is. This is the more interesting one, centroid SIA or summated vector mean. So this takes into account the direction and the magnitude of the SIA for each individual eye. So again, we've got those same 4 eyes, same vectors for each one, but instead of just putting them beside each other and averaging them, we're putting them all head to tail to get an average direction and magnitude, and that red arrow is the centroid SIA. So that's the dot that you'd see on a diagram from the Journal of Cataract and Refractive Surgery, anything like that. That's how they've come across that. And usually that's around 0.1 diopters, which is why you often get told to put 0.1 into your toric calculators. So it does work, but again, it's not going to tell you, it's not going to predict an individual eye. It's telling you what the group did, but as you can see, all the individual eyes were all over the show. The third one, which I think is a little bit difficult for people to understand, so I'll try and break it down, is the flattening effect at the axis of the incision. And so think about these 4 eyes. I made the incision each time at 180 degrees, where I put that blue oblong. If you look at each one of those vectors, they're exactly the same, and you've got the same centroid SIA, that same red arrow, but what you can do is you can break it down into its components. So you could see there's a vertical and there's a horizontal component there, and if you wanted to look at what's the component of that vector that's acting at the axis of the incision, you can break it down further to just the horizontal component at 180 degrees. That's the flattening effect at the incision axis. And so usually that's around about 0.1 diopters also, which is another reason why it's often put into calculators. So which of these measures is the best? That's what commonly gets asked. Which one should I use? Well, it depends what you want to think about. If you're wanting to look at, does my incision cause a lot of change in shape? Mean magnitude SIA is very nice. It's a good overall rounding. Centroid SIA is good for considering a population and making sure you've treated each of those eyes exactly the same. So same incision, same location, same IOL, all of those things the same. You get a good centroid value, which is taking into consideration the magnitude and the direction, which is great. Flattening effect, I think this is really interesting because it teaches us what is happening at the axis of the incision, because we were all taught through our training, make an incision, you'll flatten the cornea, and we all know that that's rubbish. That no longer is true. There's no good evidence for it. Maybe when we used to make big incisions, but no longer with small incisions. But remember, none of these will tell you about an individual eye. They'll tell you about the group of data. They'll tell you about that group that you operated on. But as you saw, the data's all around the clock face. So being able to actually interpret one particular eye is very, very difficult. So my recommendation when you're calculating a toric IOL, put 0 into the SIA in that calculator. That goes against what you might have been told to put 0.1, but if we're taking a gamble on where the direction of SIA is going to happen, you may as well be right with your gambling and pick 0, because that's your lowest risk possible. You don't want to even guess 0.1 and be in the exact opposite direction, which would end up being 0.2. So, we've got enough uncertainty, enough fudge factor in there, ELP, posterior cornea, why add another irregularity, something we can't predict? Since I've touched on posterior cornea, you might be thinking, well, is there posterior corneal SIA? We published a great study last year about this, and it's pretty minimal, so minimal you don't have to worry about it. We worry about it for you, so you can forget about that. So I just wanted to show SIA for toric calculation. This is an eye where I operated on 2.4 incision. You'd think it would be predictable. Instead of flattening on the incision axis, it steepened. So you can see on the steep axis, it got steeper, the flat axis got flatter. So just one-off example of why what we've been taught through our training, that you make an incision, you flatten the cornea, is no longer true. I just wanted to show some realistic data. It might look like I'm just trying to show off and show that my results are great, because they are, but realistically we achieved around about 95% within half a diopter of refractive astigmatism target, which is really good. I'm really proud of it. But why are we not getting 100%? It's mainly because of SIA. It's mainly because we're getting eyes where we cannot predict exactly what the shape change will be, and we're treating the preoperative eye and we're left with the postoperative eye. So that's why we're not getting 100% in a lot of cases. So what do we know about SIA so far? First of all, we know some average magnitudes, usually around 0.3 for a mean magnitude SIA, usually about 0.1 for a centroid value or flattening effect, and you can put that into your calculator if you want to, but as I said, 0 is better. We know that incision placement is really important, so a temporal incision is as far from the center of the cornea as you can possibly get, because your cornea is oval, and so when you go temporally, you're as far from the center, and just biomechanically that means lower SIA. If you go superiorly, you're going to be closer to the center, get a higher SIA value. On-axis incision they're not more predictable, and they don't give less of a flattening effect or more of a flattening effect. It just means that you're operating in a slightly different position, which is probably more dangerous for your patient, to be honest. Incision size, we used to make really big incisions. We used to cut the eyeball nearly in half, and that SIA was very predictable. You make a big incision, you get a predictable outcome, but it's also a predictable outcome of 3 diopters of astigmatism, so you don't really want that. Smaller incisions, the smaller the incision, the smaller the SIA. And so we've done studies looking at our corneal shape preoperatively and postoperatively for 1.8 incisions. Pretty much exactly the same result, nearly 0 SIA. 2.2 is acceptable, it's in that sort of 0.1 range. 2.4 and above, you are getting a little bit bigger, and so I think the sweet spot is probably around 2.2. Incision disruption. There's a general feeling out there that the more disrupted a wound is, the more you disturb it, the more you twist injectors, the more you enter and exit the eye, the higher your SIA will be. So less disruption makes sense. A cleaner, smoother incision should give you lower SIA. No one has really looked at SIA over a long period of time. The longest studies have been out to about a year, and it does look to continue to decrease. Someone out there needs to do this study and keep looking at SIA over a longer period of time. I think that would be really interesting to look at. No one's really seen it so far. So in terms of decision making, a surgeon has to decide what size incision should I use. The smaller the incision, it does make access to the eye a little bit more difficult. I find 1.8 a little prohibitive in terms of IOL choice, but it does decrease your SIA. Bigger incision, easier, faster surgery, but there is a limit to how high you want your SIA to be. So again, like I said, I think around 2.2 doesn't limit your IOL choice at all. You can enlarge it slightly if you ever want to, but it does mean surgery is relatively easy and little disruption to the incision. What architecture you'll make your incision doesn't appear to have any particular effect on SIA, whether it's a 1, 2 or 3 plane incision. It just means how much time you want to take making the incision and how easy it is to enter and exit the eye, but no big difference. And location. So like I was saying before, evidence-wise, temporal is your friend, superior is the worst. On axis, I think, is a relic of the past. I know there are a lot of surgeons that do that, and they'll probably be offended by me saying this, but really it's safest to do the same thing every time. I don't think it makes any sense to be moving around the patient, operating sometimes at 40 degrees, sometimes at 20 degrees. There's no benefit to SIA, so why are you doing it? I don't know. IOL implantation technique. Some people like to put their complete injector into the eye. I'm more of a wound-assisted technique person, because there is some evidence that slipping the IOL through the incision is a little bit slipperier, a little bit smoother, causes less disruption to the eye, maybe will give you a lower SIA. So why is SIA so unpredictable? Well, we just don't really have the link between corneal biomechanic measurements and what that does to SIA. We can measure the corneal biomechanics of an eye, we can measure SIA, but we don't have a way to predict one to the other, so we can't link the two together. So I thought, well, why don't we look at this? Why don't we see whether we can look at what features of the cornea might predict SIA? I looked at 220 of eyes that I operated on with a 2.2 incision. We looked at OCT images, 1 day, 1 week, 1 month. I haven't published this, but I think it's kind of interesting. And we saw that there were different features that stood out. So endothelial gape, epithelial gape, endothelial detachment, abnormal thickness of the cornea, and stromal retraction of the corneal stroma. So decided to give them a points-based system to see, does this correlate with SIA? Some of the features, pretty nice images, very easy to do if you ever want to do this to your own eyes. You can look at endothelial detachment. You can look at whether they line up or not. It's interesting. This is what stromal retraction looks like. And on the other side, that's a perfectly healed 2-part incision. So that's meant to be biplanar, but you can't really curve a blade. So they always give you a curved incision when you're looking at it on OCT. Looking at the disruption score, there was a difference between the different lenses and injector types. And I won't go into the details of what they were, but there was a difference in disruption depending on the technique used. So that did correlate to lower SIA, which was interesting. And so when we looked at what are the features that do actually give a lower SIA and a lower disruption score, the key one was stromal retraction. So it does seem as though the less you disrupt the wound, the less stromal retraction you get and the lower your SIA, which I think is an interesting finding and one that's been backed up by other studies also. So on average, you're going to get lower OCT disruption, giving lower magnitude SIA. Stromal retraction will be lower, and ideally what you want is a smooth, non-disrupted wound to reduce your SIA. You want the smoothest incision you can get. What's the impact of SIA and residual astigmatism? Well, it's really high. You're going to get unhappy patients and unhappy surgeons, and annoyingly the way that you fix residual astigmatism is surgically, which can induce more SIA. Unless you've got access to a laser or a friendly refractive surgeon, it can be difficult. You're going to have to go back inside the eye, and that means more SIA, more unpredictability, so you're better to get it right the first time. I helped develop an online tool for deciding how to manage residual refractive area called Toric Pro. You don't have to use it, but we do get monthly reports on who does use it and why they use it. So over the past 6 months, I had quite a few users from around the world. Nearly 40% of analyses of why things went wrong with toric implants were due to SIA. So it is a major problem, and I think it's something you need to consider if you're wanting excellent refractive results. So just in summary, we've got SIA being unpredictable, but you can keep it low. When I say unpredictable axis. You don't know where it's going to act around the clock face. Incision stretch and disruption will give you higher SIA, and it can have a major impact on outcomes. So my evidence-based opinion, if that's a term, is a temporal incision will give you your lowest SIA. It makes surgery simple. You're doing the same thing every time. I can't see any reason not to do it, so it makes sense. A clean, smooth incision without disruption makes sense also. You're going to get less retraction, less damage to your stroma, less SIA. For me, I think a 2.2 incision is a real sweet spot. Easy to use without disrupting, low SIA without limiting my IOL usage. And when you're implanting a lens, implanting a toric and you're calculating it, use 0 for your SIA because that's the safest method. It's going to give you the most predictable results. If you feel you must put something in, 0.1 would be a maximum. Now, this is a topic that I really enjoy talking about, obviously, but if you would like to get in touch, ask anything about it, more than happy for you to contact me. Thank you very much.